So thank you to everyone for joining us today. I'm going to review some of the housekeeping for today's session. You will all be watching the session via the HOVA app, and through this app, that's where you can ask questions to the speakers from our sessions today. The questions that you ask are specific to the speaker or to the session. Each talk will be 10 to 15 minutes in length, with then 5 minutes for questions at the end of the talk. You can upvote the questions in the app for the questions that you would like answered the most. If we don't have time for all of the questions during the question periods for the session, we will try to address some of them during the panel discussion, which is the last session for today. In order to attend the next talk, you will need to click on the link in the agenda in the HOVA app. So please click each of these links to progress to the next session. As I mentioned, the last session today will be the panel discussion. The panelists will need to switch between different session links, so it may take a few moments between our last speaker's talk and starting the panel session, so please be patient with us if there is a delay. And if there is a delay, then the final panel discussion may extend for a few minutes past the scheduled time. So it is now my pleasure to introduce Dr. Michael Ackerman, who is going to be providing the keynote lecture today. Dr. Ackerman is a professor of medicine, pediatrics, and pharmacology at the Mayo Clinic in Rochester, Minnesota, and is the director of the Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic. He's internationally recognized for his extensive work in clinical and translational research efforts in the field of heritable cardiovascular disorders, genomics, and genotype-phenotype relationships in heritable cardiovascular diseases predisposing to sudden death. He will be speaking to us today about upper limit of normal versus disease. How do I rule out long QT syndrome in borderline cases?
Well, Dr. Escudero and everyone, can you see me? Can you hear me?
Yes.
And can you see my slide?
Yes, we can.
Well, congratulations to you all, and thanks for doing this. I am about ready to set my timer. Oh, we're not even live, are we? We are actually virtual. So masks off, but don't forget, I mask, you mask, we all mask together. I'm thankful to be the keynote. You can set your timer now. Mine's 15 minutes, and I hit the start button now for my assigned time. I'm just the warm-up act for everybody else, and we're gonna take 15 minutes to unpack this borderline case issue, which really is about QT confidence and competence, getting it just right. I'm conflicted. These are my relationships with industry to disclose. I don't think they're going to affect our ability adversely or negatively to do this, to assemble skills, to reveal some pearls, and identify the cutoff values that will warrant further investigation to really make you QT competent, QT confident with navigating the borderline issues. Sometimes it's easy, isn't it? This is obvious long QT syndrome, nothing borderline here, must be extreme QT prolongation, therefore obvious long QT syndrome, a 1 in 2,000 condition for which some of us are well acquainted with, but not so fast. The owner of this ECG doesn't have long QT syndrome at all, just has a little too much cesium toxicity. So remember, extreme QT prolongation does not equal congenital long QT syndrome, even when the QT interval isn't borderline at all. Now, instead, it's going to be drugs or electrolyte abnormalities that give us extreme QT prolongation. So don't get fooled. Don't immediately think long QT syndrome. Remember, the QT drug hit list website can be incredibly helpful for your practices. How about this one? Nothing borderline here. This is called L-normal, isn't it? It's as normal as they get. So borderline case, borderline difficult? No, not abnormal at all. But this patient absolutely owns a long QT causative mutation, no doubt about it. And it serves as a vivid reminder that we have to do mutation-specific genetic testing when we have long QT established. A normal ECG in a family with long QT syndrome cannot rule out long QT syndrome. Only the genetic test can. Well, how about here? We're going to really delve into this, the QTC value Borderline, you've heard that expression. That's where the expression of borderline cases come from. So maybe a borderline length of repolarization, but is this a borderline look of repolarization? Not at all. In fact, it is the length and the look of repolarization that prompted the great Peter Schwartz to once say, Michael, I don't measure the QT interval, I look at it. And so there are looks of repolarization that can take a borderline length and maybe tip off the presence of a not so borderline long QT syndrome, an obvious case, such as these genotype specific looks of repolarization. So we got to figure out how to get it just right. And can we rely on the computer in these cases? Well, remember this one from just 3 minutes ago? Extreme QT prolongation, not congenital long QT syndrome, but also extremely missed by our ECG reading room, to which I like to say that the computer-derived QTC is accurate, plus minus 400 milliseconds. Now, it turns out that it's actually quite good overall. And in fact, Sammy Viskin has taught us a sobering message that the QT by the computer is actually better than we are. And the goal of the next few minutes is to help make all of you joining us to be better than the heart rhythm specialists and the 3/4 of cardiologists who got the QT wrong. Why is this really important with respect to the borderline cases? Well, this is now an old study, 13 years old, where this was the profile of 176 consecutive patients who came with a referral diagnosis of long QT syndrome by a heart rhythm specialist, both pediatric and adult. And when they came through our program, definite in a quarter, possible in a third, but look at this, fully 40%, we said, not so fast. And in this context, genetic testing will be extremely helpful for you, because when we said it was clinically definite, we got a positive test result in 75%, 38% when I said possible. And when I said no way, not there, not feeling it, the genetic test was negative. Important point, if the genetic test comes back negative and you're still going to call your patient long QT syndrome, timeout. Take a really close look at the strength of the clinical evidence. Back then and still now, 40% of the patients that came to Mayo Clinic with the diagnosis of long QT left without it. The two most common errors, sins of commission, if you will, is overscribing a wimpy story, a vasovagal faint, getting a borderline QT interval, and then moving them to long QT syndrome. We need to stop that. The other is egregious QT interpretations like this ECG from one of those. Completely normal, but you can see what somebody underlined and marked right there, for which they said the QTC is not normal, it's actually very prolonged. And so we had to both undo this mistake and remove the patient's defibrillator that was implanted for an overdiagnosis of long QT syndrome. So how do we get the QT just right in these cases, whether it's borderline or not? We need to go back to the basics. We need to do what Arthur Wildis said, teach the tangent or avoid the tail. And when you and I are confirming the veracity of the computer's quantitation, we need to do this. Go down the isoelectric, take the isoelectric segment, go down the downslope, and intersect it there, and resist the urge to do the sin of QT inflation by U-wave inclusion. And then when you've done that, and I give you these next 5 things, you're going to be a lot better than the 3/4 of cardiologists and even the 1/3 of heart rhythm specialists who are QT challenged out there. And those 5 things are, first, use lead 2 and V5 for your QT confirmation leads. Stay away from V2 and V3. Go down to V5, look at there, put your eye or your calipers in the QT interval and sensor it there, and then look, and if your QT interval matches the computer's, you're done. You verified the QTC because the computer can do RR really well. On the fly, if you can see that the QT is less than half the RR interval, the QTC will always be less than 460. That doesn't rule out long QT syndrome. It just tells you quickly that you're under 460. Be careful in sinus arrhythmia. Don't take the maximum QT and the minimum RR. That will grossly overestimate the QTC. Take the average. And then remember that the patient's QTC truth will break down at slow heart rates. You're going to underestimate the truth, and it'll overestimate at high heart rates. But one of the things I see way too often in pediatric heart rhythm programs is somebody with a QT of 500, heart rate of 50, getting called prolonged QTC because they're just stating the absolute QT. That's not going to be good. That's going to swing it in the other direction, and we'll illustrate that. Bonus is the wide QRS adjustment, for which you then normalize it as if the QRS or depolarization was normal. An extra bonus, patients with congenital long QT syndrome almost never have a wide QRS. And so that can help you. And then if you take these and you can censor the QTC better, which one are you going to act on? What level bothers you? And this is really important to get this right, and we haven't understood very well the distribution of QTC in health and disease. This is the average of our entire program. And when it's way out there in genetic long QT, high risk, of course, almost never seen, 600 almost never seen, lines in the sand for risk at 530, but the best line in the sand, never forget, never disrespect, is the QTC 500 millisecond line. You may have stumbled into long QT syndrome incidentally, and if they have genetic long QT syndrome, it's not a borderline case. It's an at-risk case. But here's the dilemma of QTC values in our long QT patients that had normal and can be really normal, like as normal as they come on the left. And then juxtapose that is where the official word borderline came from, the 440 line. And borderline QT prolongation has gotten incorrectly translated to borderline long QT syndrome way too quickly, because that's a lot of people. Now, replacing borderline is the 450 line for men, 460 line for women that satisfies a guideline definition of prolonged QTC. But if there's no story, no nothing, almost never going to be long QT syndrome. So nothing borderline about that case. So how do I do it? Remember these lines in the sand: 480 women, 470 men, and 460 before puberty. And act on those lines. These don't equal long QT syndrome. They equal about a 10% chance of having come upon long QT syndrome. So if your index of suspicion is story driven, you don't like the story, you don't like the ECG, you don't like the treadmill stress test, they get the full court press, they get the drill. And so we have to come back to the story. Are you bothered by the story? Does that faint bother you? Does that seizure bother you? Does the timing of that spell with the auditory trigger bother you? And if yes, we're not dealing with a borderline case, we're dealing with the possibility, the real possibility of long QT, for which we must do long QT genetic testing. On the other hand, no story, incidental loma, and their QTC is below those cut points, get out of that situation, dismiss them. Don't call them borderline, dismiss them. Now, if they exceed those cut points, 480 women, 470 men, 460 before puberty, do a bit of a drill. The best, repeat the ECG, get an ECG on the parents. And if those follow-up tests fall below those cut points, get out of there. Dismiss them. Don't call them long QT syndrome. But if they exceed that in any of them, commence the drill. And again, the drill is going to include the genetic test. It's a guideline recommendation. It has been for 9 years to get genetic testing. Never disrespect the 500 line. You may have stumbled into it, long QT syndrome, if there's no story, and you cannot blame it away on drugs. If there is no exogenous acquired factors, you now have a greater than 50% chance that you have stumbled into long QT syndrome. So even if asymptomatic, get the genetic test. And again, if the genetic test comes back negative, the story better be really good, because by itself, the genetic test rules out 80% of all congenital long QT syndrome. So I mentioned it once, I'll mention it again. Do not disrespect the QTC 500 millisecond line. Now, 2 minutes on my counter, and I leave you with something that's an incredibly useful free resource that was born out of the COVID-19 pandemic, and that is our online QTC calculator by the chief architect, Alan Sugru. So use this, go to this website. It can help you a lot. It can teach you a lot. So when you go to the website, you can go to the calculator and type it in, and you can look at your patient. Your patient is 12 years old, and you measured by those tools 500. And then you see here that the heart rate was 50, and you type in 50, and you say, wait a second, not so fast, 456. Don't use 500 there. But now the heart rate was 90, and now you're dealing with that for the QTC. Now, if the QT was 450, and now you have a QTC. So this can help you tremendously. Take advantage of this resource after you've applied it to the QT measurement that you made. So I leave you with the counter at 1 minute. These 5 take-home points. First, extreme QT prolongation does not equal long QT syndrome. Second, normal QTC values do not rule out long QT syndrome, especially the families. Only the negative genetic test result can get you out of that borderline case. Third, there might be a borderline length, but there's not anything borderline about the look. Remember, not only the length of repolarization, but the look of repolarization. Fourth, avoid those tails. Do not commit the sin of QTC inflation and subsequent long QT overdiagnosis because of that U-wave inclusion. And then last, if that long QT genetic test is negative, that story and that ECG better be very compelling. So I have 5 seconds to thank these entities for partnering with our program to help us heal the sick and advance the science. And I would love to have you join us next in 10 months in Vanderbilt if you want a little bit more, a lot of it more, on the genetics of heart and vascular disease. So I'd love to see you questions you have. Thanks for having me. And then I'll be back again after these 5 minutes in the full speaker powwow with all of you. Thanks, everyone.
Thank you very much, Dr. Ackerman. That was an excellent talk. I don't see any questions right now in the Whova app, so anyone who's watching, please feel free to put in any questions, which we will ask the speakers at the end of their talks. So perhaps I'll just ask you something. In terms of trying to rule out long QT syndrome, how do you use the exercise test? What sort of values do you use, and what timing do you look at repolarization during recovery?
Well, I think there's a couple things there, Carolina. First, the exercise stress test is really an LQT1 challenge. So it's a great test to unmask concealed LQT1, and there the money is in the recovery phase, where a QTC greater than 470 milliseconds at 3 minutes of recovery, 4 minutes of recovery, doesn't really matter which, both are equally predictive, has about a 70% positive predictive value that you have unmasked LQT1. So I think the stress test is very good for that. It's reasonable for LQT2 because you have so-called QTC latency that emerges with a difference between the recovery QTC at 5 minutes and versus the one at 1 minute. The other part where the stress test is helpful, obviously, is monitoring your satisfaction with your level of beta blockade. But I think people have forgotten that the stress test really is, at its best, an LQT1 challenge assessment. It doesn't rule out all long QT syndrome, for example, but it's a great great test to unmask concealed LQT1.
All right, Mike, I received another question that asked if you don't pay attention to the raw QT on a bradycardic patient, how do you interpret the QT or the QTC in those patients?
Yeah, I think the biggest thing there, Tony, is that I've seen, I can't tell you how many times where the QT was 500, the heart rate was 45, 50. So the QTC would measure by Bazette, say 440. And instead of reporting the 440, they report the 500 absolute QT as the QTC. When instead the QTC truth in that setting of bradycardia is going to be somewhere between the Bazette's underestimate 440 and the raw QT. So the raw QT will overdiagnose big time. The Bazette's will miss a few. So what I do then is I'm aware of that. I think about that. And then I say to myself, okay, what am I going to get in their QTC when I have them on a stress test? And now I'm in the first minutes of the stress test when their QTC is moved from 45 to 65, 70, where the performance characteristics of Bazette's is better. And then see what happens to the QTC number. Is it similar to at the bradycardia, or did it become very different? And so I think the biggest appeal I would have to the pediatric cardiology and the pediatric heart rhythm community is don't report out the absolute QT in the setting of bradycardia as if that's a closer approximation of QTC truth. You just swung the pendulum exactly in the wrong direction towards overdiagnosis when you've done that. Just keep it in mind, see what happens to the QTC when the heart rate moves. Even in the office, you could just have them walk around to get the heart rate out of the 45 zone and into the 60, 65 zone and remeasure their ECG and things like that.
Great. Thank you.
Yes, thank you very much. There are a couple other questions that have come up, but I think for the sake of time, we will save those until the panel discussion. So for now, for going to the next session, for those of you in the Whova app, please remember to click on the link in the agenda.